Assalamu alaikum. I will present three different cases of internal abdominal hernias. First case, 40 years old female patient present with recurrent left upper abdominal pain and distension. Before I review the image, I will show the normal anatomy of anterior pararenal space. As you know, composed mainly of pancreatic tissue, second and third duodenal, and also ascending and descending duodenum, and there is no small bowel segment here. In our case, that I show you the radiology CT scan, we see a small bowel segment embedded in the left anterior pararenal space, causing compression of the pancreatic tissue and stomach anteriorly. Our landmark here is the anteromedial compression of the inferior mesenteric vein, which is usually drained to the splenic vein. Here we repeat the exam after 24 hours. We found the positive contrast inside the hernial sac that embedded positive, means that the content of the hernial sac is part of the transverse colon. This diagnosis of this case is left paraduodenal hernia, which is usually located in the Lanzard fossa, lateral to the jejunal flexure, causing anteromedial compression of inferior mesenteric vein and ascending branch of left colic artery. And this is the most common cause of internal abdominal hernia. Next case, please concentrate again in the anterior, left anterior and right anterior pararenal spaces. We have also cluster of dilated bowel in the left anterior pararenal space, causing compression of the pancreatic tissue anteriorly, and also compressed of the inferior mesenteric vein anteromedially. This also left paraduodenal hernia. What is in the rest here? We see the transverse part of the duodenum, which is third duodenal segment. Infralateral to the third duodenal segment, we saw another bowel loop interrupted here, causing anteromedial compression of the superior mesenteric vessels. The diagnosis in this case is left and right paraduodenal hernia. The same case, we have left and right paraduodenal hernia. Right paraduodenal hernia is located within the Walder fossa, behind the root of small bowel mesentery, infralateral to the transverse part of the duodenum, the third duodenal segment. Third case, present 13 years old female, 1 month after appendectomy, present with signs and symptoms of small bowel obstruction. What see here? We see dilated fluid-filled small bowel segment, and we see here another small bowel segment dilated, located lateral to the collapse cecum and ascending colon, associated with engorgement of adjacent mesenteric blood vessels. Diagnosis here, pericecal hernia. Pericecal hernia is common in elderly women, can mimic appendiceal disease. What is the definition of the hernia? Hernia is defined as protrusion of the abdominal content, most commonly small bowel, through a peritoneal and mesenteric aperture into a compartment in the abdominopelvic cavity. It accounts about 60% of small bowel obstruction, with overall mortality about 50%. Causes of internal abdominal hernia can be congenital through normal foramina or recesses, or unusual aperture resulting from anomalies of peritoneal and attachment and internal rotation. It can cause by inflammation, trauma, and surgery, especially gastric bypass surgery for bariatric treatment and liver transplantation. Clinical picture ranging from long-standing history of indigestion, periodic cramp, and abdominal pain, postprandial pain, which relieved by change of the position, and intestinal can complicated by intestinal obstruction and strangulation. This is the classification of internal abdominal hernia. I already prescribed left and right paraduodenal and pericecal. The other type is transmesenteric hernia, which occur along the small bowel mesentery, start from area of the ligament of threads to ileocecal junction. This type of hernia now increase in their incidence due to gastric bypass surgery, especially Roux-en-Y anastomosis. Other type of the hernia is foramen of Winslow hernia, which is located between the stomach, liver, and pancreatic tissue, and also can cause gastric outlet obstruction and obstructive jaundice. And the other type of hernia, also there is transsigmoid mesocolon hernia, which is usually located between the sigmoid colon and left psoas muscle. We also have transomental hernia in the periphery of the abdomen among the attachment of the greater omentum, and we have also supravesical hernia. And the most common cause of supravesical hernia is broad ligament hernia, which is located between the uterus and ovary. CT scan is the imaging modality of choice in case of acute abdominal pain complicated by small bowel obstruction, with overall sensitivity and specificity approaching 90 to 100%. Multi-doctor CT scan, multiplanar reconstruction, volume rendering, and maximum intensity projection add more confidence for diagnosis. Use of the contrast media is mandatory. A key point to diagnose internal hernia: cluster of small bowel dilated in abnormal anatomical position, sitting of small bowel obstruction, convergence of vessels and mesenteric fat at the hernial orifice, displacement of K mesenteric blood vessels, injurement and twisting and stretching of mesenteric vessels if strangulation occur, CT sign of transmural ischemia, including loss of wall contrast enhancement, pneumatosis intestinale, portomesenteric and pneumoperitoneal, and lastly, abnormal displacement of surrounding structure around the hernial orifice. Small internal hernia can be present by small bowel obstruction, in which unlucky bowel segment interrupted within the hernial sac cause U or C shape dilatation of the bowel, in which it is obstructed in two approximate edge. One edge is called the oral edge, and the other edge is called the anal edge. This liable more strangulation and ischemia. You must note that CT scan cannot detect peritoneal and mesenteric ligament unless they're outlined by ascites. CT scan evaluation of internal hernia can be negative during symptoms-free interval due to spontaneous reducibility of the hernia. Differential diagnosis of internal hernia, including small bowel volvulus and which have whorling appearance, adhesion diagnosed by exclusion of the other, and history of operation and presence of the transition zone between dilated and collapsed bowel segment, interception, impregnation of bowel in each other, and sclerosing encapsulated peritonitis, or what is called cocoon syndrome, in which cocoon syndrome, in which there is accumulation of the bowel surrounded by fibrous capsule, usually post-inflammatory, post-trauma, post-VB shunt. Conclusion: although internal abdominal hernia are uncommon, should be taken in consideration in any case of small bowel obstruction complicated by strangulation, especially in the absence of history of previous operation or external hernia, and especially if there is present of history of gastric bypass surgery. Radiologists should be familiar with their anatomy and location, helping the surgical doctor for appropriate for perioperative identification and therefore appropriate management, reducing the mortality and morbidity for the patient. Thank you.
Thank you for all doctors for their beautiful lectures. And now
بسم الله
for
الرحمن
the
الرحيم الحمد لله رب العالمين.
questions from the audience. Any question? Thank you. We will transfer to the second session.
دكتور نشوان دكتور سيف يلا بسم الله. ما فيش بريك بين الجلستين يا شباب عشان تتغدوا
مرسلين
نواصل.